Josh, thank you. So ahead of this meeting, I had prepared a very nice angiojet case, and then this came. Of course, all complications and difficult cases happen on a weekend and late in the night, as this was. No disclosures. 60-year-old male presented with 1 week of chest pain. And therein lies the problem, Here we've been running around doing STEMI interventions. I just completed 25 years of doing it. And the patient in Miami, here is a patient, 1 week of chest pain, and he has not. And he comes with worsening short of breath. Patient is pale, hypotensive, with the blood pressure of 80 systolic, and EKG is showing a straightforward infraposterior MI, first-degree AV block. And the patient was intubated in the ER and rushed to the cath lab. Okay, here we go. So here are the images. The left system, I was quite surprised. I thought maybe there is a separate ostium of the LAD. But if you take a look at this relatively small, somewhat under-perfused LAD, it does keep going to the apex. And there is a occluded RCA, and at this stage, I go ahead and put in a impella catheter, pacemaker, and to aortic root shot to ascertain that there really is no other separate ostium of the LAD. And the patient not only continues to be hypotensive, but has a asystole cardiac arrest at this time. I have no idea what's happening with the images here. And this is all PCI performed. I was actually quite surprised. I was able to get the hydrophilic wire down the RCA, and this entire stenting of the RCA has been done with ongoing CPR, as you can notice. And the final is the result of the RCA, nothing to write home about, but decent. And in the meantime, we got the patient, we got the hemodynamics back. The patient is severely hypotensive. Very, very frustrating seeing him really not improve that much, actually. At the end of the procedure, he has an impella, he has a pacemaker, blood pressure is still no better. And we move him to the ICU. And this is what we found. Very large VST. And now that explains what has been happening to this patient right from the moment he presented, late presenting MI, infraposterior MI, and this terrible VST. Just to complete the academic part of it, almost 1% of acute MIs will develop a VST, classically between day 10 to 14. This patient kind of fit there. Highest incidence on day 1, and then day 3 to 4, 60% involving the anterior wall, 40% inferior wall. The anterior walls are actually somewhat simpler and more located towards the apex. And this mid-anterior wall in this particular case is far more complex and associated in addition with RV dilatation and MR, which are complicating the cardiogenic shock. Now, what happened to the patient, I'll share with you in a moment. It's a rapid fire unraveling of Harrison's textbook of medicine with the worsening desaturation, the patient going into very quickly into DIC, worsening shock, maximum pressures, diabetic ketoacidosis, worsening metabolic acidosis, and acute kidney injury, and dialysis was initiated. Now, in 25 years of doing STEMI-only practice, I've had, this was my third VST, and the previous two had humbling outcomes. This one I'll hold on for a moment to tell you what happened. But at this point, understanding very clearly what we were dealing with, the surgeon was contacted. This is around 11:30 in the night on Friday. And of course, it was understandable, his hesitation. And I mean, if there are any cardiac surgeons here who would say that they would immediately jump on, then you have a job waiting in Miami. So I sense that, and at this point, understanding what I was dealing with, and again, this is not something your usual complication. I said, look, early next morning, I said, look, maybe it's time to seek some wisdom from some better people. So I immediately reached out to 6 people, 3 cardiac surgeons in Miami. I reached out to Dr. Kinney, who was gracious enough. She was going through security on heading towards India. And I also reached out to a very dear colleague who's a young, very bright structural heart guy, to reach out to him that maybe with all the doubts on the surgical intervention, maybe we need to consider putting one of these amplatzers. And of course, at this hospital, we didn't have a technically smart person doing this. So early Saturday, we tried to get him a 1-case privilege and made out all these calls to Abbott Vascular to see if we can rush the devices. And the patient was way too unstable. And my best conversation, which is on the left-hand side, is with Dr. Barry Love. I was hoping he would be here in the audience. Dr. Love is a pediatric interventional cardiologist whom I have come to admire and respect over the last almost 20 years. I have known him. And this is what I wrote to him after making all the arrangements. Personally, I think the ventricle, that's his reply, have worked phones incessantly and have now secured both CTS, which is planned for later today, with VST repair plus ECMO, and percutaneous repair the next morning. And I asked what his view was and put him on the spot. And he said, look, really, if he's forced to choose, he will probably go with the VST closure plus maybe a 5.0 CP Impella or ECMO. And of course, as luck would have it, and to make this number 3 humiliating, humbling case, the patient, way before he could be taken to the OR, the EEG demonstrated no brain activity, and he was pronounced. What are the take-home messages? I mean, as I cited to you, 3 cases over 25 years of STEMI. All 3 had a poor outcome. I thought maybe the last VST was 14 years ago. I thought maybe we've become smarter, that the surgeons have become maybe a little more aggressive. 17 publications on it, larger being a study from a meta-analysis from Greece with 3,400 STEMIs reviewed and about 86 VSTs. Mortalities was 86% in the first 24 hours. I don't really know the right answer. All I can tell you is that absolute wake-up call. I think this patient, we had almost a 36 hours dilly-dallying where he should have been rushed to surgery. In my note to the surgeon, I said, look, this is your chance to be a hero. I mean, the family was prepped, we were prepped, we knew what we were facing with. And my only take-home message here was that, of course, I'd like to get this wonderful faculty to talk about the percutaneous options, but I think we lost the window by not taking him immediately.
Thank you, Dr. Mehta. It's a great case. Dr. Lasala, want to make a comment?
Yeah, so we've certainly had enough of these under our belt to get an idea of what the mortality is based on the time course. COVID was a real stimulus for this. We used to see maybe 6 or 8 a year. We were seeing 4 a month because people delayed coming in having their infarcts. Acutely taking them to the OR probably is not a good idea anymore. Doing them percutaneously acutely is not a good idea. So, everybody knows that if you wait 2 or 3 weeks, they do better. Well, that's a self-selected population, so that's not feasible. So the only thing you can do to sort of rationalize the best way to manage this is to stabilize them for 7 to 10 days. You started to intimate that you should probably just put in a 5.5 Impella. When somebody presents this late and their RV's blown, you probably also need to provide right ventricular support as well. So we favor putting in a 5.5 Impella axillary, putting in a Protect device to support the RV if they need it. We don't want to shunt more blood, but we're not doing anything in the first 7 to 10 days. It's also selecting out the people, unfortunately like this, who have no brain function left or minimal neurologic function left after cardiac arrest, and we'll let you know right, the next few days whether or not it's even worth doing anything at all. So I think this sort of cooling off period, if it's possible, should be performed. I think that's probably the best way to do this, and then deciding how they look at that point, and using that as a time to decide what the optimal intervention period is.
Yeah.
Whether they go for percutaneous closure, the next step, versus surgical closure, depends on some other factors. Clearly, a high STS score, I'm going to get that case. I'm going to end up doing it percutaneously. Somebody that looks like they're relatively straightforward from an STS standpoint and has a big hole should go surgically. Posterior basal ones, in addition to having some of the other problems you mentioned, often have a very complex, larger hole that becomes difficult to plug. Getting the post-MI VSD device from Abbott doesn't work because it only goes up to 24. Most of these are way above that when you've got somebody that's shunting this much blood. So you have to end up with an ASD device, and that won't work in a large hole in the posterior basal segment. That's really for apical VSDs. So you have a lot of decision points to make. Are they viable or not? Stabilizing 5.5 is mandatory with plus or minus RV support. Looking on down the road, how much have they recovered? What do you think the potential for recovery is? And then deciding, what their STS score is, and is the hole amenable better to surgery or for percutaneous closure?
Yeah, thank you so much. The comments are well taken. There is actually a review of all the post-MI mechanical complications in JACC recently. We did this review, and the hardest paper to get through the reviewer was the VSD. And the reason is the group that I contacted has a great experience in Holland, and they are pregonating end organ damage prevention. Exactly what you said. So these patients rapidly deteriorate, and if you put them on mechanical support device, then you can stabilize them and hopefully operate exactly as you said. Or if the tissue allows it, go for percutaneous, but it's very controversial. The specific issue of this case is very interesting because at Sinai, we have probably one every 3 years or 4. And if the operator has done a small LV gram, if it is allowed, if the hemodynamically is allowed and your LV-EDP is not 40, we routinely do it. And we pick it up. In the RIO projection, you can see the double shadow. So we teach our fellows to, if the MI is stable enough that you can do an LV gram, do it. Because intervening just gives the cascade of the anticoagulation and all these issues that makes it more difficult. Any other comments?
I want to, John, respond back to you. You're absolutely right. I mean, this is no fun for the surgeons. I mean, they almost universally have. In this particular case, his course was so rapidly worsening that I really think we had no chance to stabilize him and to wait that he'll make it to 7 or 10 days and that surgery would be easier. And this has bothered me. I mean, it's been 10 days of suffering. He's a relatively young patient. You get pretty emotionally involved with the family seeing all this. I would still venture, I would take him to surgery, maybe push the surgeon harder.
And
Disagree.
For a senior person, that Dr. Mehta, that has done under the belt probably more than 10,000 MIs, putting an Impella up front means the patient was really unstable. Any other comments? Yeah, go ahead.
So the only question I have here is, I'll tell you, with this late presentation, with the EKG changes were not that dramatic, and the patient presented pretty sick. So that's the issue. So, usually you just, retrospect, we can look at all this stuff, but even it's an educational case, really for us to learn from is when they present like this, then you worry about mechanical complication up front, number one. And number two is, do we really need to open the artery? And what happens with these people is the amount of reperfusion injury they get in that area, and especially if you're thinking about percutaneous closure, they become so mushy with bleeding that as soon as you put a device like that, we've had in our old-time experience, that device goes up and goes to the tricuspid valve and stuff. So I think reperfusion injury in this case is a big problem. So the question is, should you just put an ECMO, do this stuff, and forget about the artery, or should you open the artery? And that's the question, we think about these things.
Your comments are very well taken. In the inferior posterior VSDs, the trajectory of the actual defect is serpentitious, and there are multiple connections. So this is an intramural hematoma that ended up remodeling into multiple defects. So your comments are right on the spot. And there are two different approaches. One says, yes, revascularize, other says no. Surgeons sometimes don't revascularize, just go for the VSD repair because that area is gone. So in the review, we have all the techniques that Bill Daggett and others describe to repair these lesions. Any